So the next video is all about the lateral elbow. We'll have a few minutes chatting about differential diagnosis, followed then by the assessment of the lateral elbow and things that can contribute to symptoms. And then future videos will be looking at different treatment options for lateral elbow depending on the driver. So if we have a patient that presents to us with pain around sort of lateral elbow, is within the kind of age range that generally you would expect, and has pain with repeated wrist extension, finger extension, gripping over hand, that kind of thing, then obviously we'd be thinking, could this be tennis elbow? If the patient has some more sort of posterior lateral elbow pain and has a history of things like trauma, so falling on an outstretched hand, or things like repeated lateral elbow injections. So some of the evidence shows that patients that have repeated lateral shoulder injections can have an odds ratio of up to 20 of developing lateral instability. So the odds ratio, I'm sure you all remember, is basically, it's not a causal link, it's an association, but they found people that did have repeated injections were 20 times more likely to develop posterior lateral rotatory instability of the elbow. If a patient is very sporty and does lots of gymnastics or overhead activities, bowling, then I could be wondering if they got some kind of posterior lateral impingement. We could also have problems with the radial capitellar joint, so between the radius and the end of the humerus. So we can have obviously osteoarthritis in that joint. We can have inflammatory arthritis in that joint. We can have infections, and if your patient is quite young, we can also have something like osteochondritis dissecans of that radial capitellar joint, or in that radial capitellar joint. Now, obviously, looking at whether somebody has an inflammatory arthritis, such as rheumatoid arthritis, or if they have a septic arthritis or a reactive arthritis, although it is rare with the last two in the elbow, theoretically it could. So we would be looking for our classic inflammatory signs. So does the patient have early morning stiffness for a good hour or more? Are the symptoms better with movement generally, not eased with rest or worsened with rest? Do they wake up during the night, in particular the second half of the night? Do they have any other symptoms which could be suggesting it? Are there any signs of swelling in that joint? Have they had any blood tests? So have they had ESR or CRP? Have they had rheumatoid factor? Have they had anti-CCP? Or if you're thinking a connective tissue problem, have they had ANA done? So that all helps to build up a picture. We can do x-rays to obviously look for things like erosion or osteoarthritis. In some cases, you might be able to see osteochondritis dissecans depending on the size of the problem. So it will be, if we're thinking those kind of things, that we'll need x-rays and possible blood tests. Obviously, with reactive arthritis, then usually it is preceded by either sexual related infection or a abdominal infection, and that is a good question to screen. If it is a septic joint infection, then obviously what we're looking at is there any local changes to that area? If they had any scratches and bites, or falls and banging into something, things like that. But obviously this is not a lecture on sepsis. This is just differential screening. So we've gone through tennis elbow, posterior lateral rotatory instability, posterior lateral impingement, so in the lateral aspect of the olecranon fossa. We've talked about the radial capitellar joint, which it does consist of or have pathologies that can affect, such as osteoarthritis, osteochondritis dissecans, And inflammatory pathologies like rheumatoid arthritis, reactive arthritis, septic arthritis, although the last two are rarer, as a cause of the lateral elbow. Moving down, we've also got the radial tunnel. So to get that, as we mentioned before, you are going to get the lateral epicondyle, 5 fingers. It's a nice position actually to do it like that. So you're coming down and you can press there. So that could be a cause of the lateral arm, lateral elbow pain. If it's radial tunnel, as we said in the video, you generally don't get neurological symptoms distally. You will get the pain here, which can be a dull ache. If we are thinking, or if the patient with your lateral arm pain, lateral elbow pain, does say to you, look, I'm getting weakness in the wrist extensors, finger flexors, well, we know that's not tennis elbow for a start. It's not radial tunnel syndrome either. It will be most likely to be the posterior interosseous nerve. So we look at the strength of the muscles that nerve innervates. That includes the extensor carpi ulnaris. That includes extensor digitorum for the fingers. That also includes extensor digiti indices for the index finger and extensor digiti minimi for the little finger. And also some parts of the, not some parts, the supinator. So we can test supination strength, we can test wrist extension strength, we can test finger strength, and if that is weaker but with no pain, we can start to be looking at, is it the posterior interosseous nerve, not radial tunnel. And again, with the actual posterior interosseous nerve, it is rare. In fact, we don't get neurological symptoms such as tingling, numbness in that area. We get the weakness. If we are getting sensory changes in the radial side of the posterior aspect of the hand, we're looking at the radial sensory nerve, and then you can do sharp, blunt, 2-point discrimination, hot, cold, and things like that as well. The other things it can be as well for the cause of the lateral arm is, as we said, problems with the neck. So as we mentioned with the referral, so we're looking at sort of C6, C5, C6 down to C7, 8. Possible referrals can go to the lateral arm depending on obviously how far it goes. So we can consider that, and we have to consider that. But also we need to make sure and assess the shoulder and shoulder blade, because there are some good research, which I will be going through in later videos, that show the positive effect of incorporating the shoulder, rotator cuff, scapula strengthening in the tennis elbow program, which actually does provide relief. So in conclusion, the differential diagnosis of lateral elbow pain can include tennis elbow, posterior lateral rotatory instability, posterior lateral impingement. It can be coming from the neck, so C5, 6 to C7, 8 depending. It could be coming from a shoulder problem. So we know, and again, as I said, you'll see more evidence in further videos, that strengthening of the rotator cuff and scapular muscles can help improve tennis elbow. Coming down, it could also be radial tunnel syndrome. And coming down, if it's more weakness in the hand, it could be posterior interosseous nerve. So there are lots of different things that could contribute to the lateral elbow, lateral arm pain. It is not just tennis elbow. I hope this video has been useful, and any questions, please let me know.